if you can't fly, then run. But if you can't run, then walk. If you can't walk, then crawl. But whatever you do, you have to keep moving forward, not become static, and ultimately you will reach to your destination. It was saying of the Dr. Martin Luther King Jr., who was assassinated for liberating the black man's independence, black man's liberty. Now, basis of the resistance, there are two bases of resistance. One is genetic, as the name is, one can understand that is chromosome mediated, plasmid mediated, transposon mediated. And the other is non-genetic basis, that is, that has got no role with the genetic transfer of the. So, coming to the non-genetic basis, antibiotic do not reach in the center of the abscess, so you have to have the ancient drainage of the abscess, as the antibiotic are not able to reach the abscess. Presence of the foreign body like surgical implants, catheters, splinters and shrapnel, that also hinders the perfusion of the antibiotic in those areas. Penicillin does not affect those bacteria which are not growing, means not effective against static bacteria. Wall-less bacteria are insensitive to the cell wall inhibitor and antibiotic because these are meant to cause the lysis of the cell wall, and those which do not have the cell wall, these are insensitive for these bacteria. Wrong drug, wrong dose, and failure of the patient to take drug. So remember 4Ds. 4Ds mean diagnosis, drug, dosage, and duration. The common resistant pathogens which show resistance most of the time, they are staphylococci, pseudomonas, enterobacteriaceae like Proteus, E. coli, Salmonella, Shigella, Klebsiella. Similarly, Acinetobacter, Citrobacter, Enterobacter, Streptococcus, Pneumococci and Enterococcus, and Gonococci and Meningococci, and the Mycobacterium tuberculosis, all are notorious for having resistance against the antibiotic. Now, mechanism of antibiotic resistance, number one is mutation in bacteria, number two, enzymatic degradation of the drug, number three, modification of the drug target site, number four, decreased entry of the drug, and number five, rapid ejection or efflux of the drug, and number six, the other drug resistant mechanism by which the drug is not able to affect the bacteria and bacteria do survive. Bacteria can possess one or all of these mechanisms which have been given above simultaneously for their survival. So the number one is mutation in bacteria, chromosome mediated resistance, plasmid mediated resistance, transposon mediated resistance, and mainly seen in the tetracycline group of antibiotic, that resistance is seen, that is via spreading by these. I have already told you this resistance, but here one can see the mutation again, and that is what the mutation do here. As one can see, the mutation is a change in the DNA that can sometimes cause a change in the gene product, which is the target of the antimicrobials. And as you can see that the bacteria, they are just going to have the antibiotic which is coming, and the DNA virus gene is affected, and that is going to cause the killing of the DNA virus and ultimately the killing of the bacteria. Now, this DNA virus ultimately becomes resistant, and so the antibiotic is not able to do, and the bacteria can survive. So here one can see the DNA virus that become resistant, and the antibiotic which is coming to just kill it is not able to kill but just pass from it, and the result is the bacteria can survive happily. So that is the mutation. Now, the next is enzymatic degradation of the drug. Here, it is also called metabolic inactivation of the antibiotic. Here, the bacteria possess gene which produce certain enzyme. These chemically produced enzyme destroy or modify the antimicrobial before reaching to the target site and to have the effect. This is seen in case of the penicillin and chloramphenicol antibiotics. Beta-lactamases enzymes are produced by the many bacteria. As the name is beta-lactamases, these are produced by the different bacteria to destroy the beta-lactam ring. So these are effective against the beta-lactam antibiotic. So these beta-lactamase inactivate penicillin and cephalosporin by cleaving the beta-lactam ring of the drug. Chloramphenicol acetyltransferase enzyme that is being produced by the bacteria that inactivate chloramphenicol and the aminoglycoside. So these are not able to just kill the bacteria. So here one can see the beta-lactam ring of the penicillin, beta-lactam ring of the imipenem, and beta-lactam ring of the cephalosporin, and the beta-lactam ring of this clavulinate. All these rings are destroyed by the enzyme which is named beta-lactamase enzyme, and that make all these antibiotic insensitive or not working against these bacteria. Now, here one can see that how enzymatic degradation occur. One can see that many bacteria possess genes which produce enzymes that chemically degrade or deactivate the antimicrobial, rendering them ineffective against the bacterium. So here one can see the porin molecule of the bacteria, and antibiotic is just getting entered from this toward the cytoplasm. In the cytoplasm, the enzyme beta-lactamase is produced, which is capable of engulfing these antibiotic and just render these antibiotic ineffective by chemically degradation. And here again one can see that enzymatic degradation, how it happens for the more convenience. Now see, the bacterium porin allow the antibiotic to get enter, and when it get enter and reaches to the cytoplasm of the bacteria, this enzyme produced by the bacteria engulfs and make this bacteria ineffective. So the bacterium is not able to do anything against that. Here one can see how the enzymatic degradation occurs. That is destruction or inactivation. Many bacteria possess genes which produce certain enzyme that chemically degrade or deactivate the antimicrobial agents. Here one can see the porin of the bacteria do allow the antibiotic to come inside, and when it comes inside, the enzymes being produced by the bacterium that is capable of engulfing the antibiotic, and that is just not allowing the bacteria to being inactivated by the antibiotic. So the next is modification of the drug target site. Bacteria synthesize modified targets which receive antibiotics. So antibiotics has no effect, like DNA gyrase that is modified by the many gram-negative and strep pneumoniae make fluoroquinolone inactive. Penicillin binding proteins are modified by the methicillin resistant Staph aureus MRSA and penicillin resistant S. pneumonia make the penicillin inactive. Now, modification of the drug target site is the gram-positive cell wall modified by the Enterococcus species make the vancomycin inactive or insensitive. Similarly, ribosomes, S. pneumoniae, staphylococci species, and Neisseria gonorrhoeae and Derrick gram-negative rods, these are just having the modification of the ribosomes make the tetracycline, macrolides, and streptomycin inactive. Similarly, the next point is decrease entry of the drug, reduce permeability of the cell membrane that prevents the penetration of the drug. Result is no effective intracellular concentration and accumulation of the drug occurs. So the change in the porins reduce the amount of the penicillin entering bacteria and Pseudomonas bacteria, which even does not allow carbapenem to cross the membrane, and there is altered influx in the gram-negative bacteria and there is altered efflux for the tetracycline. And here one can see the double membrane of the gram-negative bacteria, and that is outer membrane. It do allow the antibiotic to enter and to pass through the porins, but the inner membrane, and that does not allow the antibiotic to enter into the bacterial cell. So here one can see the decreased entry of the drug, that is the outer membrane, that is the porin, transport in peptidoglycan, cytoplasmic membrane, and plasmid. See how the antibiotic enter into the bacterial cytoplasm, but these transport molecule does not allow the antibiotic to get into the bacterium cell. So this is the decreased entry of the drug. Similarly, the altered porin molecules, here one can see the outer membrane and the porin and the transport protein, and see that as the antibiotic to try to come and to enter into the porin, these are just going to become narrow and does not allow the antibiotic to allow its entry. So that is the altered porin molecule which does not allow the antibiotic to get enter. Now the next parameter is rapid ejection or efflux of the drug. Bacteria actively transport or expel drugs using a multi-drug resistant pump called MDR pump or efflux pump. It export or kick out variety of the drugs including the quinolones, so no intracellular accumulation of the drug occurs. Antimicrobials enter the bacterium through channel termed porin, and these are expelled, pumped out or kicked out of the bacterium body by the efflux pump of the bacteria. Pseudomonas bacteria against many antibiotics like tetracycline and macrolide use this mechanism. Here one can see the efflux of the drug, how it occurs. One can see the porin molecules, and that is the transport protein which allow the antibiotic to get inside. But there is one more new transport molecule, the pump, which is a flux pump that just make the antibiotic out and kick out the antibiotic, so the antibiotic cannot stay inside, and that is how it occurs. See it again as the antibiotic enter after passing the foreign molecules, these are being taken into the bacterial cytoplasm, and but the bacteria have developed a new pump which is called a flux pump, and that have made out the drug out of the bacteria. Now, other drug resistant mechanisms are replacement of a sensitive pathway, then acquisition of the resistant enzyme sulfonamides and trimethoprim. These antibiotics are just made insensitive because of the resistant enzyme. Then metabolic pathway for the sulfonamides does not allow the antibiotic to get enter into the bacteria, and overproduction of the antibiotic target titration that is applicable in the sulfonamides. So these are just a few mechanisms, and this is how one can hold the sun or the moon in his hand if one is willing to do that. And this is very beautiful and nice photography by one of the very nice photographer. Now, summary of the resistant mechanism, as I have told you the different way as antibiotic get enter, that is being enzyme degraded, and that not allow it. If they do get enter, these are pumped out. Some does not even allow the entry of the bacteria, or the antibiotic target are just changed. So the antibiotic which thinks to work on the ribosome, the shape of the ribosome is changed. Similarly, the different part of the antibiotic, these are changed, and the antibiotic is not able to diagnose and to just search the target where it has to go and work. So this is again the summary. One can see that decreased uptake, a flux pump, not allowing the entry, and when it get entry, the wrong target that is given to the antibiotic. So these are just the way by which the antibiotic are inactivated, and the target site is not detected, and the antibiotic does not work. Even the decrease intake or influx and efflux does not allow. Now the consequences are there is increased number and the length of the hospitalization, and more difficult management of the infection. There is increased morbidity and the mortality, and the choice is more expensive and more toxic therapies, change in the empiric antimicrobial therapy, and the previously wonder drug which were working, natural penicillin, tetracycline, now become useless and are resistant. So what is the way to prevent this by the WHO? Judicial use of the antibiotic mean minimizing antibiotic use, antimicrobial drugs not to be taken for the viral infection such as cold, cough or flu. Do not pressurize your clinician to prescribe an antibiotic unnecessary when there is no need. Use narrow spectrum antibiotic and use optimal dose and regimens. Do vaccination, infection control measures, and improve sanitation. And the research for the new antibiotic is there, regimens and the improved medical devices to prevent the infection, and take medicine exactly as prescribed. Do not save medication to treat yourself or the other later. So the take-home message is C4D, diagnosis, drug, dose and duration. Use combination if necessary. Economical empiric therapy, step up or step down after having the culture sensitivity and recognizing the bacteria and the antibiotic. Proper hand washing, soap and water for 30 to 30-second minimum. Rapid and reliable diagnostic and susceptibility test. So that was the end of the antibiotic resistance, and Hope so that may you have liked it. If you like it, please press subscribe it. And if you don't, just have any question or query, please do not hesitate to talk to me. I'm ready to give answer to your question. And thank you very much for your patient listening and watching.